The following podcast is part of a certified educational activity titled Taking the Lead in Timely Diagnosis of AD, Incorporating Biomarkers into Routine Patient Care. Access the entire activity and complete the post-test at peerview.com/XSS860. Downloadable slides and practice aids are also available.
Hello and welcome, everyone. Thank you for joining us today. Well, we really want to welcome you to Taking the Lead in Timely Diagnosis of Alzheimer's Disease. My name is Sharon Shaw. We'll get you through the rest of this today, and hopefully you'll have a lot of fun. I'm from Stanford University. I'm chief of the Memory Disorders team at Stanford, and with me I have Dr. Ali Autry from Banner Sun Health. I have Dr. Henrik Zetterberg. So we're going to start with our first polling question. All right. Which of the following is the greatest barrier or challenge to optimal biomarker-based diagnosis and treatment of Alzheimer's disease? Would you say A, selecting and interpreting available biomarkers such as CSF, PET, or blood-based biomarkers? Would you say 2, the lack of widespread implementation of these plasma biomarkers? Number 3, aligning biomarker results with treatment implications and making shared decisions? Or 4, I give up, all of the above are significant barriers and challenges. So the current healthcare and practice gaps in the detection of and diagnosis of Alzheimer's disease, really the timely detection and diagnosis of the symptomatic Alzheimer's disease. These are ones that are clinically in the stage of mild cognitive impairment. And really, it's critical to diagnose patients in this stage, the symptomatic early stage. Few patients are diagnosed at this stage, this early stage, outside of research settings. Recent estimates indicate that only 8 to 15% of individuals with mild cognitive impairment receive a diagnosis of mild cognitive impairment. And even at later stages, many patients with dementia go undetected or uninformed of their diagnosis. Greater than 40% of mild dementia cases go undetected by their primary care doctors. And 55% of individuals with Alzheimer's disease are never told they have the disease. And now we have validated imaging and fluid biomarkers. We have experts here to tell us about that today. And they're not routinely used in the diagnosis of mild cognitive impairment Alzheimer's disease. And we're seeing evidence throughout this conference today about how important and how it's been changing the field. So even though they're proven to change the management of these patients 60% of the time, they're not being routinely used. So the benefits of receiving this diagnosis, I don't need to tell everyone here, but it is important. Not only does it validate the concerns of the patient and family, it really enables patients to participate in their own care, whether it's lifestyle measures or other treatment decisions, but really also treating and addressing their comorbidities. We really can then understand and facilitate access to their personalized support services, whether it's diagnosis, treatment, support care, social work, etc. And the biomarker confirmation that is required and recently required for the approved amyloid-targeting therapies for Alzheimer's disease. And then clinical trials. A lot of patients and families are interested in hearing about clinical trials. So that diagnosis is important, not only for the currently approved therapies, but also participate in the research. So our goals for today are to improve your understanding of the link between Alzheimer's disease-specific biomarkers and the trajectory of cognitive and functional decline across the disease spectrum. We want to equip you with strategies to effectively use these biomarkers testing to confirm the Alzheimer's disease pathology in patients with cognitive impairment and determine eligibility for these amyloid-targeting therapies. We want to improve your ability to engage patients and care partners in informed discussions. What do we do in clinical practice to really work together with patients and families so they understand the risks and benefits of undergoing these treatments? And then reflect on the learnings, not only from workshop today, but ones that we've hosted before, such as at AAIC in Philadelphia. So let's start with a case. Bernice, she's 59 and a retired botanist with 18 years of education. She has about a 15-month history of progressive memory and cognitive decline. She was referred to your specialized memory clinic from her primary care doctor. She has had trouble with word finding and frequently forgets appointments. Her daughter, who accompanies her to the clinic, today says, yeah, I recognize that she's also having these cognitive problems, and it has been progressive and difficulty with repeating questions and stories. They both acknowledged a high level of emotional stress since the passing of Bernice's husband, approximately in the same time frame of that 15 to 18 months. So, as we think about Bernice, I'll tell you a little bit more about her past medical history. She has hypertension, hyperlipidemia. She's being treated for this with atorvastatin and lisinopril. She lives in a rural area with minimal health care services. So think about that as we talk about infrastructure. And her family history is positive for dementia in her mother at the age of 90. Her primary care doctor did a Montreal cognitive assessment. I'm proud of that primary care doctor. I don't get a lot of those that do that where I'm from, so good job. Her score is 25 out of 30. Her PHQ-9 score was 16 out of 27, indicating moderate to severe symptoms of depression. And the functional activities questionnaire was only 3 out of 30, suggesting that she's relatively independent. She has some difficulty with her taxes, but can do them on her own. And her structural MRI shows very mild bilateral parietal and hippocampal atrophy. So you're going to hear about Bernice throughout this conversation today. There may be some details about Bernice that we change along the way, but think about her as we discuss some of the topics here today. Now, I don't need to remind all of you here about the neuropathology of Alzheimer's disease, but I will recap a few major concepts. And some of the things that we're thinking about in the pathological spectrum is not only about the A-beta pathology and the tau tangle pathology, but also the synaptic dysfunction and the neuronal injury. We now have biomarkers that can detect some of this. That then leads to neurodegeneration. But we're also recognizing that there are other pathophysiological mechanisms at play, not only with the calcium and iron related injury and neuroinflammation, but vascular compromise, comorbid synuclein pathology, or comorbid TDP-43 pathology. And so we know that in 2024, just last year, the Alzheimer's Association updated the research criteria and really to highlight some of the developments in the biomarker research area that has been suggestive of understanding this pathophysiology. So it's really focusing on the stages rather than the etiologic specificity. And we now recognize that it's this Alzheimer's disease neuropathological changes, and recognizing that some of these core biomarkers occur at different times. And the core 1 biomarkers are earlier, whereas the core 2 tend to happen later in that neuropathological spectrum. And that T1 and T2, and I'll show you another slide about this, represents early tau changes versus later tau changes. And that biological definition of Alzheimer's disease can occur in asymptomatic individuals with positive biomarkers suggesting a diagnosis of Alzheimer's disease. Now, we contrast that to the International Working Group, who proposed an alternative definition of Alzheimer's disease, saying that this is a clinical biological construct, and those who have these biomarkers at an asymptomatic stage may be considered at risk for Alzheimer's disease. So you can see that there's some developments in the field. We're still trying to understand what's the best terminology. Is it semantics? We recognize that there are pathological changes that we can detect by biomarkers. And this slide is really highlighting that we can see that these different core 1, core 2 biomarkers, that in a core 1 represent the A-beta and tau, and we can see it in the middle column, these fluid biomarkers, and on the right column, the imaging biomarkers. And really to highlight that we've got some earlier stage in the core 1 and a little bit later stage in the core 2, but recognizing that we have biomarkers for representation of neuronal injury, inflammation, and comorbidities with vascular compromise, as you can see in imaging, or now that we have synuclein representation of the seed amplification assays, we can really understand comorbidities. And no talk on Alzheimer's disease is complete without the schematic by Cliff Jack. And the revised little lines that you see on the left are really looking at those core 1 biomarkers represented by the fluids and the A-beta, but you can see some of the p-tau now added there, and then a little bit later by tau PET, and then we see the clinical changes and others. So Polling question number 2. I think this is number 2. We'll go back to Bernice. And as a reminder, she's 59. She had symptoms that began about 15 to 18 months ago. She has a family history that's positive in her mother at age of 90. Her MoCA's 25 out of 30, PHQ 9, 16 out of 27, FAQ 3 out of 30. What would you recommend next? Would you do some AD biomarker testing for her diagnosis? Order some neuropsychological testing? Prescribe an SSRI? Prescribe a cholinesterase inhibitor? Or I don't know, let's send her back to her primary care doctor. Now, Dr. Attree whispered to me, what would you do? Now I'm going to throw that back to him. What would you do, sir?
Well, I'd have a discussion with the patient, the family, always. But I think in this case, I want to know that 25 out of 30. What was the pattern of the of what she missed?
Yeah.
Do I need neuropsych testing? No, but it is pretty early. FAQ was 3 out of 30, which meant she's relatively independent. I always really do like neuropsychological evaluation. So as a baseline, I would like that for her. So that's where I would probably start. And then we could talk about biomarkers and other things after that.
Yeah.
And I'm a laboratory physician, so but why wouldn't one focus a little bit on the depressive symptoms and try to? I'm a little bit surprised that, of course, perhaps not prescribe an SSRI, but still evaluating that a little bit further. There is no rush, right?
Oh yes, yeah, I would really want to look further to see is it apathy, is it something else, is it truly depression? Yeah.
So I think then that leads into your section next. But I think I would say, because I'm over time on my section, I probably would do all of the above, but have that discussion.
Yeah.
I would. And so I was sort of cheating. There wasn't that answer there, but I probably would discuss all of those and work in parallel.
And I have to say, as far as treatments go, I never do two things at once. So I would never do a SSRI and the cholinesterase because I'm not smart enough to know which one's doing what.
You're right. I wouldn't do it.
But if I really thought she was depressed, that there was
one versus,
I would start. Yeah. So anyhow, lovely to be here with all of you. And as far as biomarker testing, et cetera, goes, I want to, the who's really important. So who are we talking about? The who is a patient with symptoms and who has a concern. Either you have a concern, the patient has a concern, or a family member has a concern. And really, there's objective findings. So, currently, this is not really recommended for people without symptoms or who feel like they're at risk. And based on a patient-centered discussion, you want this information to be actionable. So it requires really counseling before and after. And of course, it could be to really make an accurate diagnosis, a timely diagnosis, which could also potentially affect, prognosis and also therapies. Just a couple of things I want to say is that in general, we're going to give you a lot of information on these slides. We'll try to summarize them. The slides are all available for you. So that's the whole point, is that, not to read the slides. And then we want to also leave time for questions at the end. So if you have questions at the end, we'll take them. One of the things I want to say is that after 7 years, the Alzheimer's Association had a work group that came up with the process of evaluation and counseling and disclosure. And I was fortunate enough to be a work group chair on that with Brad Dickerson, and that has just been published in a special section of Alzheimer's and dementia. And there's 3 executive summaries that basically talk about 19 recommendations that went through 7,000 papers and Institute of Medicine review about just the process of evaluation, history taking, what instruments to use, and how to use the biomarkers. And we put a place in for tau PET and blood-based biomarkers, but we actually didn't put those in yet. We did things like CSF, amyloid PET, FDG PET, things like that. And that's actually very consistent with Frazzoni et al. That was published just last year. That was the European societies that they also did a Delphi process. And you can go through and see how to use those processes. But all of them really start with a patient with symptoms. So what are the biomarker modalities that we have? And Henrik is going to talk really more about those with you, but all of them have their pros and cons, right? Ultimately, we know that the blood-based biomarkers are the things that are going to be most accessible and are going to be tier 1 and 2 tests that are going to be used. Are we ready for prime time yet? Probably not completely, but we're getting there soon. What does amyloid PET or PET scans give you? Well, they give you one modality, but they can give you spatial information. They're less accessible. They're more costly, but they also give you information that's a little bit different from the fluid biomarkers. Now, CSF is something that's been tried and true for a long time. It's very quantitative. It can give you information about multiple different analytes, but it may not be accessible to everybody. There could be some contraindications to that. Probably as time goes on, there'll probably still be a use for PET scans and CSF, both in confirmatory situations, maybe things that are equivocal, but also in clinical trials. Now, what does amyloid PET look like? For some of you that may not work in the clinic, it's what I call 50 shades of gray. So it really, what you end up getting is clinically, you get a positive or negative. And if you have experienced raters, really experienced raters, and the standard of truth is neuropathology, that's about 95% or so, maybe 95 to 97% accurate. But if you can look at the positive versus negative scan, a negative scan looks like trees in the wintertime with no leaves. And it looks like the trunk and the branches that are just showing the white matter. So the gray matter is not, is differentiated. Now, a really positive scan is there on the bottom, where you don't see the differentiation between, the gray matter and the white matter. Ultimately, in clinical trials or certain research situations, we can get centiloid reads to put everything on on the same scale. Apples and oranges become apples, and we can compare different tracers. That's really, really useful. And ultimately, in some trials, the threshold for experienced raters is about, let's say, about a 25, 26 to determine a positive scan. Some of the studies, for example, like preclinical studies, they require you to have like maybe more than 40 centiloids. But the thought is that potentially 20 or above is at least showing that there's some amyloid there. And so that's something that's useful. All right, so now we're going to go into some of the questions.
Question.
Go for it.
I know that I know we should move on, but are you able to use centiloids in your clinic now?
Really not in my clinic. We don't have that capability. What we can do is in research.
Yeah.
So there's a computational lab we have at Banner, and I usually ask Yi Su's team to convert that, and that is very useful because you can show those pictures to participants, etc.
So I think there's variability in where people can. And most centers don't have the centiloid availability, which gives us the quantification.
Correct.
Yeah.
So this is just a little bit of a discussion. I thought the timer is going to switch to 5. If you can switch that, because I thought we were supposed to have 5 minutes. We can switch the timer up for our discussion here. But this is a follow-up to actually what was some questions that came up at AAIC. And one of the first questions was, what about using tau PET in clinical practice? How could that be useful? Now, I'll give you an example. If imagine you have a patient with actually in the dementia stages. So you can say that they're actually in mild dementia stages, very symptomatic, not even an MCI, and their amyloid is positive, very clearly positive. So they're A positive, and let's say you also do a MRI, and that's positive, N positive, let's say. Now, what if I told you did a tau PET scan and the tau PET scan was stone cold negative? What would you think of that? So if you go to for example, the Alzheimer's Association criteria, you can see they propose actually not only the staging in the clinical spectrum, so in this case, there would be stage 4, mild dementia clinically. And then they also suggest staging based on A, B, C, D on tau PET. But in this case, you would have a negative tau PET, so there would be a stage 4A. So is amyloid the driver of their symptoms?
So, I think it really depends on the phenotype of the patient also. So, I've had cases, they're rare, where a patient is young, and maybe they don't have an amnestic phenotype. And I would still expect, say, they have a logopenic or more language symptoms, or maybe they have posterior cortical atrophy with more visual, spatial difficulties. I would still expect there to be some tau deposition, but there can be discrepancies. So if I really thought it was an underlying Alzheimer's disease, I might suggest CSF and see if with those fluid biomarkers, maybe we're capturing it.
Something earlier.
Yeah.
So what if I changed it and say that she's 83 years old, 4 years old, very amnestic phenotype, has been progressing over many years, amyloid positive, tau negative.
Then we need some more biomarkers, TDP-43 and some other things.
TDP-43, right. So very big hippocampal atrophy, let's say.
But in this context, I think actually, perhaps not in an 83-year-old, but here neurofilament light could be a little bit useful, at least. But now she's old, and then it's a noisy marker. But if it had been a younger person, I would be interested in a neurodegeneration marker also. So yeah.
Yeah. So I think there would be a place in some ways, but one of the issues is that tau PET, for example, even though we have one approved in the U.S., reimbursement is still an issue. Standardization is an issue. We don't have the really good measures for quantification, for example. But it is something to think about when you're thinking about whether amyloid is a driver or not of somebody who is very symptomatic in the dementia stages, and maybe that amyloid is true, but less related, possibly. All right. Should we take another one? So in that case, I think it could be a mix. It could be a mixed condition, right? So it's the second condition. And what about FDG PET? Anybody use it still? Do you use it, Sharon?
I don't use it very much. Yeah, do you, Henrik?
But I think actually it's used a little bit more in Europe than in other parts of the world. So I think we would hear some European neurologists state that they perhaps would have liked to do that.
Yeah.
And in particular, in that situation, when in that last bullet, CSF is indeterminate, maybe we want to pull in, like you're saying, as many biomarkers as we can that's available and clinically available for patients to help us with the diagnosis. Sorry, interrupted.
Yeah, no, I think sometimes as a proxy even of the tau PET, I think there's a little bit of an overlap between in somebody who whose symptoms are driven by, let's say, tangles, etc. You can use the FDG PET. So I think there is still a role for FDG in many cases. All right, so I think we're going to move on. So, Henrik, I think it's you.
Now it's me, CSF. CSF is this fluid that surrounds the brain, and you find it also deep in the ventricles, and it communicates freely with the brain interstitial fluid, as you all know. And you can take it. I mean, I am from Sweden, so we say you can take it easily by a lumbar puncture, which is like a back scratch. That is a Swedish perception of
use that in
CSF sampling. Yeah.
Remind me not to turn my back on you, Henrik.
Be careful when you come to Sweden. There is a big risk that and I mean, it's really my favorite body fluid, and if one can be so personal to say that in this context, it's such a beautiful and clear fluid if you have sampled it right, and if it's yellow, it's something wrong, and red is not good. Water clear, then it can still be Alzheimer's. And then we measure, of course, a lot of different proteins in CSF. And the nice thing with CSF, if you work as a clinical neurochemist or a clinical chemist, is that you can measure a number of biomarkers in this biofluid and get a pattern. The most important CSF biomarker, if you're interested in Alzheimer's disease, is the E-beta 42/40 ratio. And this then comes with this fact that all of us produce beta amyloid. 42 amino acid long beta amyloid is more sticky, as all of you know. And that is also very visible at the bench if you work with pure peptides. It really is a really aggregation from peptide if you have those two last C-terminal amino acids. So if you have amyloid buildup in the brain, almost immediately A-beta 42 will be selectively depleted from the fluid and end up in the plaques. And in the lumbar CSF, you will have a selective reduction of A-beta 42 over 40. 40 is much more water soluble. So this ratio is really specific to amyloid plaque pathology. And if one does a direct concordance study with amyloid PET, one can see that the concordance is almost 95-97%. And the discordant cases, the PET people don't like when I say this, but it seems like CSF A-beta 42/40 drops a little bit before amyloid PET signal becomes positive. So you start by having a high normal ratio. Almost everyone younger than 50 is like that. From the age of 50, especially if you are an ApoE4 carrier, there will be people dropping in the A-beta 42/40 ratio, and a few years later, amyloid PET signal will start to appear. And you will not get any anatomical information from the CSF A-beta 42/40 ratio. The anatomical information you will get from PET. But from a diagnostic standpoint, in the clinical phase, it's irrelevant. So we often say that you can use these two markers, amyloid PET and CSF A-beta 42/40, interchangeably, depending on what resources you have. And I will, of course, also talk about the blood biomarkers in this context. But then we also measure total tau in CSF and phosphorylated tau. And when plaques form in the brain, surrounding neurons will phosphorylate and secrete tau. They are still alive, but they are then affected by amyloid pathology. So CSF phosphotau and total tau increase. For a while, this was thought to reflect leakage from tangles, but that's not the case, and it doesn't make sense from a biochemical standpoint. Phosphotau and total tau come from neurons that are still alive, but affected by amyloid pathology. And it almost looks like a pruning mechanism. So synapses don't want to be close to plaques, then you phosphorylate tau, tau lets go of the microtubuli, and phosphorylated tau will be secreted, the N-terminal part, the microtubule binding domain will stay in the neuron, and in normal conditions undergo lysosomal and proteasomal degradation. But if that system is overflown, you have free-floating MTBR tau that can start to form tangles. So we think about CSF A-beta 42/40 as a direct, no, perhaps not direct, but a relatively direct measure of amyloid plaque pathology, and phosphotau and total tau as a neuronal reaction to amyloid, predictive of tangle formation. That sort of summarizes the CSF test. And these are available now as FDA-approved tests, and you can use it clinically. We often like to add in neurofilament light also in this panel, because then you get NFL then as an axonal intraaxonal protein, when that leaks out in because of any type of axonal degeneration or injury, you have that as a general neurodegeneration marker. But CSF NFL and also plasma NFL has a very clear age-related increase. So in older people, it will be hard to make sense of that marker. So if people are older than 75, 80, I would almost advise against looking at it. It starts to increase in an age-dependent manner from the age of 50, which is very irritating, but a fact. But if you get a neurodegenerative disease, it goes up more strongly. From a differential diagnostic standpoint, I think it's super useful, especially in the case where you have a person with depressive symptoms, and the person is 60, and you think about Alzheimer's, you think about depression, you think about FTD. In FTD, NFL is a very good marker, actually. It also works in ALS and in Huntington and in multiple sclerosis. So in people who are 60, 65, 70, I really recommend measuring NFL. Here you just see the concordance between A-beta 42/40 and also some people like to use a ratio between phosphotau 181 and A-beta 42. I don't like that. I mean, it works, but I don't like it from an intellectual standpoint. I don't like ratios when there are two. I mean, phosphotau is for me the neuronal marker, and A-beta 42 is the plaque marker. And I want to see them separate, but it works to separate Alzheimer's from controls. So how to interpret? Sometimes you end up with discordant results. And if we look at the test accuracy, if you use a ratio of A-beta 42/40, I mean, 10 years ago, we only measured A-beta 42. But then we struggled a bit with non-Alzheimer's related reductions in Aβ42 absolute concentration in lumbar CSF. And that happens in normal pressure hydrocephalus, then Aβ42, soluble APP forms, they all go down. And then you could falsely classify that person as amyloid positive. We also know that in cerebrovascular disease and diseases with a lot of white matter injury, also multiple sclerosis, Aβ42 concentration is lower. But then Aβ40 is also low. So the ratio of Aβ42 to 40 makes it a much better amyloid test. And there are no other reasons than amyloid pathology that we are aware of that explains a reduction in the ratio. Phospho 181 over Aβ42 works in a similar way, and total tau Aβ42 too. Discordancy between CSF and PET can be explained by this temporal change in the biomarkers. You might have captured very early amyloid pathology. But I think that amyloid PET is still regarded a little bit as a gold standard. And if you are in a symptomatic phase and you have positive CSF and negative PET, then I think PET will overrule the CSF result. I don't know if you would agree on that.
I'm not sure. I think depending on what the question is. So if we're thinking about treatment with an amyloid targeting therapy, then probably I would agree. If we're still thinking that underlying Alzheimer's disease is the driver, maybe we're catching it a bit earlier, maybe the patient is relatively mild, then maybe the CSF is overruling because we're catching it a little bit earlier. So I think depending on what our goal is, but and the patient dynamic, what the symptoms are.
If you have done a lot of biomarkers on your patients and you end up with slightly discordant result, it's very common that people are also, that you will find when you scrutinize the results, that they're close to the cut points. So this is our artificial way of dichotomizing, which is, it probably indicates that these patients to some extent have gray zone pathology. So you can potentially be a little bit reassuring to the patient that if it is some pathology, it's not much at least. Now, blood biomarkers. CSF testing, I thought for many years that we would have to continue to do CSF testing because it was so hard to do reliable measurements in blood. The concentrations are super low. These molecules swim around in a mess of albumin and other proteins that are like, you have tons of it if you compared with a little bit, a few milligrams if one would do that calculation in of the important markers. But now we have access to reliable tests that can measure these proteins at very low concentrations. But now we have this polling question. And what I would like to ask you now is if you think it's time for the widespread implementation of blood-based biomarkers in primary care. And then one answer is yes, blood tests are more accessible and can lead to earlier and wider screening. Yes, blood tests could allow for faster and more efficient diagnosis and treatment. The third answer would be yes, early detection of AD pathology through blood biomarkers could enable timely intervention with disease-modifying treatments. The fourth answer is no, the interpretation of blood biomarkers results can be complex and requires specialized expert evaluation. And 5, no, more research is needed. And 6, no, widespread use of blood-based biomarkers could lead to overdiagnosis and unnecessary anxiety. But I would like to de-dramatize these biomarkers a bit and encourage you to think about them as clinical chemistry tests for brain changes. And think about them in a similar way as you use liver enzymes and or thyroid hormone tests. So you put the biomarker results together with the clinical picture. The biomarkers per se are not diagnostic. You as a clinician will make the diagnosis with the support from medical history, all other findings, calcium, B12, thyroid hormone levels, a lot of other things. And then you will consider the blood-based biomarker result. And I think we can learn how to use the blood tests relatively quickly. And if we are used to look at what one has to remember is that the blood biomarkers will reflect pathology and you will still be have the challenge to link the biomarker abnormality to the symptoms the patient has. And again, one could think about Beatrice. If we think she has a depression and we would still do AD biomarker testing and that comes back positive, it could still be that she has preclinical Alzheimer's pathology and that her symptoms are caused by the depression. So it's very important to keep that mindset and that way of thinking. And then there were some other answers that I think all of the replies were really good. Personally, I think we should start to use the blood biomarkers in clinical practice, but not overpromise, and do it in close collaboration with the patient and discuss the testing before doing the testing. That's your expertise, actually, to do it like that. But I really like that view. And then one can also, as the clinician, easily tell the patient that I'm not sure what this is. I will talk to a colleague. Let's see here. State of AD biomarkers tests in clinical care. We need to be able to make a molecular diagnosis of Alzheimer's disease now because we have access to treatments, not yet in Europe, but it's happening in many places of the world. And we are, of course, urgently trying to get it to work in Europe as well. And then it's clear that we can't do CSF sampling and PET if we think about the sheer numbers where we need to do this diagnosis. So that's another reason for why we think that we need to do it and to get it going. And then there are some reimbursement issues and there are knowledge gaps, but I think those are possible to overcome and the tests start to look good for real. And sometimes you hear that mass spec-based testing is really important to be able to make a really accurate blood biomarker test for Alzheimer's disease. But we now see when we do head-to-head comparisons that the mass spec-based test and the best performing immunoassays, also on automated platforms, they have very similar diagnostic accuracy to detect amyloid pathology. And we see some studies showing equivalence to CSF testing. So this is where I feel very hopeful that this will be possible to use. And if we think about interpreting these tests, we have to consider the clinical context. And if we are using them for screening in a preclinical setting, the positive and negative predictive values will not be good enough at the moment to interpret the biomarkers. So your challenge as a clinician will be to enrich your patient into a population where Alzheimer's disease pathology is relatively prevalent, and then you will get reliable predictive values through that. Sensitivity and specificity figures for amyloid pathology in the symptomatic stage are around 90 to 95% for the best performing blood tests. And the biomarker we are using most is phospho-tau 217 now, and you see it getting implemented in clinics around the world now, in clinical laboratories. We have a problem with a gray zone, which is results that appear in close to the cut point. If you have a 1 cut point threshold, and most laboratory specialists now advocate for the use of a 2 cut point approach. 1 upper cut point above which you are almost 100% certain there is amyloid pathology, and 1 cut point below which you are almost 100% certain there is no amyloid pathology. And the gray zone is around 15 to 20%. And those gray zone results, then one has to talk to the patient and say that it's not a clear result here, and that's probably relatively good news. If you are concerned clinically, you would then order a CSF test or a PET. You could also wait if the patient is fine with that and you don't feel a clinical need for a more urgent evaluation to simply do a repeat sampling. So wait and see and check what happens. And here you see that phospho-tau 217 appears over and over as the most accurate test. And if we compare different assays, they are very similar, but there are some assays that work less well. So the laboratory that you are using, check if they are part of the Alzheimer's Association and ADDF QC program, which is an external quality control program, and make sure that they work according to those types of standards. NFL is the general neurodegeneration marker that works in blood. Very useful in non-Alzheimer's neurodegenerative dementias, and very nice to look at in conjunction with phospho-tau217. And here we also see that there are a couple of outstanding questions. There are comorbidities like kidney dysfunction that affect phospho-tau levels. The effect size is around 10%, and one can compare that with a 200, 300, 400-fold increase in phospho-tau levels by amyloid pathology. So it's just close to the cut point. You have to consider this. And one should, of course, not use these biomarkers if the patient is urgently ill in other condition. Then it's better to get those conditions under control. There is also a lack still of studies across the world. But this is changing. And I think this year will be a major year for cross-ethnicity studies with the blood biomarkers. And if you then think about the different biomarkers to use, you can think about what you have access to in your clinic, but you can also discuss it with your patient and have patient-oriented sequential testing scheme to get to the right diagnosis. And here, let's see here, the real-world questions about using fluid-based biomarkers for Alzheimer's disease, I think we can discuss them now. And one of those questions are do we have any more insight into the accuracy of plasma biomarker cutoff thresholds for people of minority populations? I don't know if you would like to comment on that from your point of view.
No, I think you're the expert, and you just told us that there's some emerging data, but we have yet to have some of that.
I could just
right?
rapidly summarize the emerging data. And if there are very good studies from China and South Korea, where the blood biomarkers that we have seen in Caucasian populations in relation to amyloid PET now have been done in those populations, also in relation to amyloid PET, and the accuracies look exactly the same. So that is encouraging. We still have a little bit of lack of studies in African ancestries, and there is also a theoretical possibility that ApoE haplotype, ancestral ApoE haplotype, could make the amyloid effect on phospho-tau increase a little bit less strong in those populations. But the jury is still a little bit out here, but more studies are needed.
Henrik, how about comorbidities?
Yeah.
Medical comorbidities, kidney function,
kidney dysfunction,
vascular
and
medicines, other things.
Acute cardiac diseases that are not under control, they do affect phospho-tau levels in blood. But the effect is much smaller than the effect of amyloid pathology on the markers. So when we try to look at the diagnostic accuracies in populations, for example, with mild to moderate kidney dysfunction, the AUCs look pretty good, but there is an effect which one needs to take into account. It is possible that some of the ratios between phosphorylated and non-phosphorylated tau epitopes that you can get from mass spec could be more resistant to such effects. But the fully automated immunoassays for phospho-tau217, those do not get destroyed by, for example, kidney dysfunction. But one should keep it in mind.
So would you get maybe like a creatinine sort of adjusted ratio or something like that? Or
we don't think it would be needed.
You won't need it. Okay.
It's worth considering, but it's not. I don't think it will be needed, actually.
Okay.
Good. I think we should.
I think we were going to discuss the last question on.
Yeah, that last question I think might be good.
Exactly. Can blood-based biomarkers be used to determine eligibility for treatment with anti-amyloid treatments or disease-modifying treatments? Here, I think in Europe, most people would use, most neurologists and psychiatrists would use the blood-based biomarkers, but confirm by CSF or PET before making a treatment decision. In the US, I've actually heard experts do it a little bit differently. If you have a very clear clinical picture and you get a very clear blood-based biomarker result, and there are no other data, then I have firsthand heard clinicians stating that then they would feel fine with actually doing treatment initiation on the basis of the blood-based biomarker result. I don't know what how you do it.
Yeah, I mean, I think, well, one, I think we have an expert here who was an author on 2 approved use recommendations that, and I'll let you comment in a second, but just to answer your question, I think for me, I would like to know a little bit more about trajectory. We're seeing some of that in the presentations here today in terms of monitoring on treatment. But a lot of the data that we've had thus far we're using amyloid PET to guide treatment decisions about when to stop or modify or things like that. So I think it's helpful, at least at this stage, until we have more broad data, to use, amyloid PET or even CSF for confirmation. But I think we're almost there. I thought maybe you could add on the appropriate use recommendations.
Yeah, the donanemab appropriate use recommendations came out online last Thursday in JPAD, so that's available now free. And there was a lot of discussion about this point, whether we're there yet with blood-based biomarkers, and the consensus was that the answer is no at this point in the U.S., but with the clear explanation that, in the U.S. at least, once there's FDA-approved, blood-based biomarkers that hit a particular sort of robustness, accuracy, sensitivity, specificity, 90% and above, then those that meet that criteria could probably be used in the future. But at this point, the thought was that we're not quite there yet, but we may be soon.
Yeah, and we will learn from this also. I mean, I think that cautionary approach is probably good.
Okay, assessing eligibility for treatment with amyloid-targeting therapies. So I think all of us pretty much understand this. I don't need to read this, but this is really to think about, okay, who's the right patient that should be considered for these amyloid-targeting therapies? And what we're expecting is this is a stage of disease and mild cognitive impairment or mild dementia that we think is due to underlying Alzheimer's disease. So we need that biomarker confirmation. At this point, it's PET or CSF, but as we just heard, emerging is probably a plasma-based biomarker as well. Now, based on the clinical trials, there are MMSE cutoffs, and you can see the ranges here, 22 to 30 for lecanemab, 20 to 30 for donanemab, but we understand that we're not using MMSE in the clinical setting all the time, and there are guidance for things like the Montreal Cognitive Assessment or others. And obviously, there's a recommendation to include APOE for genotyping. And we understand that in certain countries like Europe and others, whether it's reimbursement or safety, APOE4 homozygotes may not be a candidate for treatment. So, but understanding and discussing with patients and families the risk based on APOE4 genotype and having that patient-centered discussion is important, so you can give that guidance about that, as much data as we can in terms of risk based on their genotype. Then obviously we need to have a baseline MRI, and the recommendations are within a year. But at some centers, we might even have it even closer in time point for when to start, because there may be some subtle increase in, say, infarcts or microhemorrhages within that time frame. And that's really to rule out the risk factors of ARIA. So those exclusions, and just to highlight them here, is that someone must be able to undergo an MRI. So those who cannot, unfortunately, are not candidates for these treatments. We need to understand and make sure that people are not at greater risk for ARIA. So that's excluding people who have significant vascular disease, whether it's hemorrhages, and the criteria are such that it should not be more than 4 microhemorrhages. But we're going to talk a little bit about details about whether it's on GRE or SWI and things like that. But really understanding that these patients should not have significant risk. And right now, we're not recommending people on anticoagulant use or great risk for bleeding and unstable medical conditions. So really, that's up to you and your patient to understand, because there are certain guidance in what those unstable medical conditions are, but there are some soft calls there that people don't fit the mold. So thinking about all of those are really what, even though there are criteria, the patients may not fit the mold. We know what the risk factors are for ARIA, that APOE4 genotyping. So 1 or 2 alleles will increase the risk. And, obviously homozygotes are the greatest risk. And then in some areas, they're not allowed. The number of microhemorrhages increases that risk. Superficial sclerosis as well. And then the higher amyloid burden, as well as the higher mean arterial pressure. So we can see, though, that the dosing, and in particular with donanemab, we see the modified titration that reduced the risk. So dosing is a factor. We understand also that the ARIA tends to occur within those first 6 months of treatment, but not only. So we have to keep in mind that it can occur later, up to 12 months or further. So keeping that in mind, that the majority of the risk is in that early sort of titration phase, but not only exclusively there. And then, treatment with anticoagulants are not recommended in the appropriate use recommendations, but some of the data is a bit inconsistent with that too. So the recommendations are to include ApoE genotype in, and again, as I mentioned earlier, that it's required in certain areas just because of the higher incidence in ARIA, earlier occurrence of ARIA, higher rate of recurrent ARIA, and more serious outcomes. So it's really a patient-centered decision, though, with you and the family members about having that informed discussion, because there may be some, and if you are in a country where it does allow homozygote treatment, to have that discussion, there may be some strong desire in patient and family, and having that understanding of that risk with them is important. And I think one other discussion from the AAIC is interesting, and I alluded to this just a moment ago in that first bullet. The difference between GRE and SWI. So in the clinical trials, GRE was used to count microhemorrhages and track that over time, but in some centers, SWI is available. So if you see a discrepancy with, say, there are 2 microhemorrhages on GRE, but 5 on SWI, what do you do? And how do you track them over time? Do you still allow them because by the strict criteria of GRE, they're allowed? Or do you have more information with the SWI and do you restrict them? What would you do?
I can tell you that if you look at the American Society for Neuroradiology, they ASNR, you put that in, and Patrice Cogswell is the primary author, and Tammy Benzinger is a senior author. They actually put out a really, really nice guidance about this. The appropriate use also has some of the stuff, but they talk about, the practicalities and also what's ideal. So ideal maybe is 3T MRI with an SWI and always on the same scanner, and the baseline and follow-up, and what should be in the neuroradiology report, for example, to help you. I could tell you in the US, every system's different. So at Banner, we're different from what's done at Stanford, what's done implemented at University of California or Mass General Brigham or the Mayo system. And so we actually we only do it in certain MRI centers in Banner, only in the Banner imaging sites. They have to be 3T machines, and we do SWI and GRE, and we compare them because the SWI is going to be very sensitive, but not very specific. And sometimes we look at the GRE to really say, gosh, is this really a blood vessel that we're seeing on end, or is this really a microhemorrhage or not? And I can tell you, it's not easy sometimes. And every person that we approve has to go to a quality review board. So we sit down and review it together. So I don't have the answer to that. It was ideal, but I can tell you that we've opted for a more conservative approach to prioritize safety first. So that's why we do both.
Yeah. And I would say the same, that we try to require as much as possible based on availability of the patient, but to require that it's, done on this, again, the same scanner at one of our scanners that includes SWI and GRE. And then we adjudicate, just like you said. So we have, much like you, very similar, sort of like a tumor board that we adjudicate with our neuroradiology colleagues, our nuclear medicine colleagues, the neurologists, and really decide whether this would be appropriate for that patient. Any comments?
Nope. I
Okay.
think that covered it all.
I don't think we'll go through all of those. So let's see what's up next. Okay. So navigating diagnostic uncertainty in Alzheimer's disease. So here we go back to our friend Bernice. And so just to remind you, she's 59. She has a MoCA of 25 out of 30. She's got hypertension, hyperlipidemia, on atorvastatin, and lisinopril. She's got the PHQ-9 of 16, so suggesting moderate to severe depression and some mild atrophy on the structural MRI. So what do we think about her differential diagnosis? Well, do we think it's depression? We already talked about, whether that's playing a role. Is it due to Alzheimer's disease or something else? She had some laboratory tests done, and that included B12, homocysteine, CBC. You can see all those there. And the results are such that she has low B12. She has intermediate p-tau217 with normal NFL, and all other labs are the same. So that makes us pause for a moment. She's got a low B12 that warrants attention. So you would tell her to take some B12. What else would you recommend? Well, 1, B12 is the key factor. Let's just follow up. 2, let's give her that SSRI we were talking about, give her some therapy, help her with a depression. 3, that intermediate p-tau217 is concerning. So let's do an amyloid PET. Number 4, actually the p-tau217 is concerning, but let's do CSF instead. And maybe this is based on where you practice. And number 5, I give up. I don't know. All right. So let's talk about Bernice, but she's slightly different here. She's again 59. Her MoCA is 25 out of 30. We know the structural MRI. Her p-tau217 was intermediate. But you ordered the amyloid PET, and that was positive, but the centiloid score was 24. It's really on that threshold of considered positive. And she had ApoE4 genotyping that demonstrated she's homozygous. She's interested in getting amyloid-targeting therapy. Uh-oh. What do we do? So we say no. She's a homozygote. It's too worrisome. 2, we say yes. Her MRI says she's at low risk for ARIA. There aren't microhemorrhages. She's okay. 3, we say no. The amyloid PET is barely positive, and there's something else driving her cognitive concerns. 4, I throw my hands up. I'm not sure. What are your thoughts here, Dr. Autry?
This is your patient, doctor. I try not to get in between you and your patient here. It's interesting because was it red? I mean, I'd like to look at the MRI, the PET scan myself. Actually, is it positive? Is it not? This could be a situation of calling Henrik in to scratch her back, possibly. Do you think that may help in this case? But I think in this case, she's pretty early on. Based on what Henrik was saying, if I really feel like this is positive, amyloid may be more of a driver in someone like her. If I had tau PETs that I could look at, or potentially FDG PETs in this person would be another situation. But what I would do is I would really discuss this with Bernice and her family, saying, look, you're falling between some of the gray zones here. There's more than smoke here, and these are the risks and benefits, and see how they feel about us, going
but
forward.
Wouldn't it be important to take care of her depression?
Oh, I'm sorry. Yeah. So I thought we were talking about the amyloid. Oh, yeah. No. At this point, again, always I'm going to look to see what's driving other things. It's doubtful that this is going to be B12. I don't think this is going to be just the depression. There's more smoke than that. All those things you want to take care of.
And Henrik, do you think that, I know you would have done CSF, right? It's your favorite fluid. Already know.
But
do you think?
I don't think it's needed in this case. Actually, I think with amyloid PET and phospho-217 both being in
the right,
a little bit in the gray zone. There is a big risk that you would end up with a gray zone CSF test result here.
And the centiloid is interesting because, again, it's an average, right? So that's why I want to look at the scan myself in many cases. So if it was red positive, is it really a few places where it's where there's blurring, as opposed to when you average things out, nobody is one number or one average, right? Whether it's your centiloids or your p-tau. But to me, this sounds like there's more than smoke.
What do you think about her NFL being normal?
Yeah, she's 59,
Yeah.
and that's really an age where NFL is interpretable. So I think that indicates that there is not a lot of neurodegeneration ongoing.
Yeah.
But of course, this could be an early case of amyloid-driven. But I still think that here one would have time to consider treating the depression, waiting a bit for
Mm-hmm.
B12,
Vitamin.
reevaluate,
Mm-hmm.
invite back.
Right.
And perhaps eventually, if one still thinks that there is, of course, the CSF could be eventually, but I don't think there is there is nothing wrong with admitting that we are uncertain here, and explain that that you are welcome back. We will follow you and figure out what this is.
The other part that also is that, I mean, she's E4 homozygous, so I know that she has a family history, but, with the E4 homozygous, again, with that clinical picture, it just seems like, that she would have, that AD may be
The driving factor there. Yeah.
early on for her, yeah.
So we have Bernice here again, but there's some things that are different about Bernice. She's still has a MoCA of 25 out of 30. She's still 59, but now she has rheumatoid arthritis and type 2 diabetes. She's taking methotrexate, folic acid, and metformin for those comorbidities. Her MRI shows mild to moderate parietal, frontal, hippocampal atrophy. She's got some small vessel ischemic disease, 2 microhemorrhages, and 1 lacunar infarct that's less than a centimeter. The p-tau217 is still intermediate. She's an ApoE4 homozygote still, but she had CSF testing. So, and now all the CSF factors are in line and consistent with an underlying AD pathophysiology. So now, here's your polling question before Dr. Zetterberg gives his comments. Would you recommend treating her if it was available? 1, no, she's an ApoE4 carrier. Not even just a carrier, I think homozygous is here. No, she has an autoimmune disease. No, her MRI suggests cerebrovascular disease. Yes, it's her decision. 5, I'm not sure. She's a complicated patient. It is, I think, 1, the fact that the CSF is more suggestive makes it less of a question, but now we have concerns about her comorbidities, right? We got to move on to you. I think these treatment decisions are between you and the family, but truly, I think we've got to counsel them with the risk factors, whether it's the vascular disease, whether it's the autoimmune disease, and I think truly the fact that she has the autoimmune disease on methotrexate with the vascular risk factors and ApoE4 homozygosity, I think makes it a lot more difficult, even though she's a more clear cut in terms of, hey, she's got Alzheimer's disease driving the pathology. It's less clear cut in the safety because we've got all these factors.
Which is exactly, again, we can discuss it. I don't need to, but I mean, I think it really comes down to having, starting the process with the patient, with the person who's affected and a care partner in a very patient-centered way to decide what the shared goals are. So you as an advisor can give them the knowledge and hopefully help them with the appreciation so they come and make informed decisions about every step of the way, including things like the biomarkers, because again, all the stuff is not for everybody. I think one thing that's really, really important is that, that timely diagnosis is really important because you want to give people that autonomy, right, and empower them at the maximum abilities to make choices for themselves, right? And that choice may mean I want to do a biomarker test, or I may want to do a plaque-lowering mAb, or I may not. It's really not about that part of it. It's about giving them that information that's reliable, that helps them make the right decisions for them. And in this era, it's great because we do have biomarkers and they are evolving, but we still have some work to do to understand them better. All right, let's see. And then realistic expectations. So I think, these are just summary slides, but, part of going through this is to explain to them in plain language, what it means. Oftentimes I spend a lot of time um, rephrasing things. They probably think that, Dr. Attree is amnestic because hasn't he told me this before in 3 different ways? But it takes time for things to settle down. And ultimately, you want to be able to, give them that appreciation about what Alzheimer's disease is and why actually having an accurate diagnosis potentially can align with their goals. Well, not, or what can align with their goals as far as having a right diagnosis and treatments. And then what modalities you choose is going to be dependent on a number of things, including, patient and care partner preference. We're going to talk a lot more about this tomorrow, but these drugs are not for everybody. And one of the most important things is to set up realistic expectations, but be able to provide them the different options. These are, I think disease-modifying drugs by definition. What's a disease-modifying drug? Well, by definition, not in Alzheimer's disease, but in medicine, it's something that works in the pathophysiology. Changes one of the core pathophysiology markers, and these drugs by changing amyloid plaques, they're doing that. They also do something to the clinical course, and the data that we have. It's important to explain that it's on averages, right? So in clinical trials, what do we get? We get efficacy, and efficacy is really telling you whether there's, for groups, there is something that is happening. It doesn't tell you about that patient right in front of you, right? That's why you can't ever abstract people to one number, whether it's their centiloids or their MMSE, right? And I always try to explain to them that I really don't know. We don't have the personalized medicine now to predict exactly what's going to happen to you, but this is what happens to groups. And then, explaining what the expectations are. These are our first generation drugs. Do we want more than 20 to 40% slowing of decline for over 18 months for groups? Absolutely, we'd like that, but we don't have more than that right now, right? And I explained to them in many ways that this is where we started years ago with MS drugs, for example. I remember when I was in the beginning of residency, et cetera, people were telling us, oh, those MS drugs, they're doing something to the MRI. That was a biomarker. They're changing things, a little bit, 20%, 30%. And then fast forward 20 years later, what you can see is the second, third generation drugs, and they had side effects, mind you. And some of them had, some major side effects. And then you can see what's happened. You can see what relapse rates have happened to MS drugs. We want to be in this position 20 years from now with combination therapies, probably with our drugs. We're not there yet. So I explained to the patients, these are not expected to be cures. And then there's the benefit side and then the risk side. So ARIA, explaining what that is. And then we're going to talk about that a little bit more tomorrow. That for the most part, we're able to do this in clinical trials. That it really depends on selecting people the right way, as Sharon mentioned to you, and it requires serial MRIs and really a partnership. That most ARIA in clinical trials really was not symptomatic, right? It was something. It's ARIA is a imaging phenomena. It's not a clinical symptom. But in about 25% of people who have ARIA, they could have mild to moderate symptoms, right? And I explained to them that in rare cases, there actually have been deaths, there have been seizures. So this is why it's really, really important that, we hear about symptoms, that people follow through if they have medicine changes. And we actually have a consent form that we have patients, go through the process. What else?
We do too.
You do too, okay.
And we have them different for lecanemab and donanemab too. So it has listed ARIA rates and risks and benefits and things like that.
Anything to add to that, Henrik?
No, I mean, in Europe, we still don't have this wonderful experience that you are building up. So it's But I still feel very hopeful now also. You talked about refined treatments and refined biomarkers. It feels like a lot of things are happening now, and that we can expect. Just thinking about what it looked like 5 years ago and projecting 5 years ahead now, it will be. And thinking about the biomarkers in blood, we have talked a lot about phospho-tau217 now, but brain-derived tau comes up. We have brain-derived phospho-tau217. We have learned that ALS can cause blood selective increase in some of the phospho-tau markers, which doesn't. You can't see it in lumbar CSF, and we learn constantly, and I think we learn a lot from clinical practice. That is, so it will be exciting to start to do this in practice.
But to understand who could respond better, how you can actually increase that potential benefit to instead of 20 to 40% slowing, maybe it could be 80 or 90% slowing. For some people, maybe you can really decrease the side effects potentially, and maybe with the second generation drugs, it'll be different. So I try to explain. Nobody comes to me and says, "Gosh, I really want to change my CDR by 0.45," right? So I explain to them what that means, what the scales are, et cetera, that unfortunately when it's misrepresented that, oh, it's a scale from 0 to 18 and, the group only changed by 0.5. And I said, look, nobody starts with an 18, right? It's really, people are chosen to be, within a few points, and over 18 months, people only move by about 1.5 points on average. And so, the idea of clinical meaningfulness is something that is very person specific. It's actually a stakeholder specific. So I try to explain to them in multiple ways, what the potentials are, including things like this. So both for donanemab and lecanemab, not only really can you see in the primary and secondary endpoints, cognition, function, or combinations, it was really pretty consistent, 25 to 40% slowing the decline for the groups over 18 months. And I try to translate that. So, that's about 5 to 7 months compared to the placebo group of saving time. Or decreasing the person's chance of going to the next stage. So if you're in the MCI stage, and only in that 18 months, there's a third less chance, for example, that you're going to go from MCI stage to the mild dementia stage, where you actually would become dependent for certain things. And, that's important for people to appreciate. All right. All right. So a quick case. This is a case, I'm not going to read it, but this is a 78-year-old with the right phenotype that actually has mild dementia. And when you look through their E3, E4, and what you can see here is that the MRI actually finds mild to moderate small vessel white matter changes, 3 microhemorrhages, 1 area of superficial siderosis, and 2 lacunar infarcts. But this person and their partner are really interested in disease-modifying drugs as soon as possible. So they're really coming to you and saying, we really want this drug. We've heard about it. So what would you recommend as the next step for this person? Order an amyloid PET, order a p-tau181 or a beta 42 from CSF, have a discussion about potential risks and benefits of these plaque-lowering monoclonals, inform them actually that the baseline MRI makes them ineligible, or you're not sure. Yeah, so I think one of the issues was that there was an area of superficial siderosis, and really, if you look at the lecanemab appropriate use and the donanemab, that's one area. Again, we don't, we may have years from now, we may know better how to deal with people with more than 4 microhemorrhages or superficial siderosis, or the idea with the anticoagulation. But right now we don't. And I think for this person, this would be a hard stop in this case, at least in clinical care, at least in my, at Banner, I would say. And whether there's a research protocol or something else, that may be different. Okay, so we're going to summarize. I think honestly, it is an exciting time for our field, and I call it the end of the beginning. I don't think it's the beginning of the end. It's the end of the beginning, but yet I think it's an exciting time. We know that that Alzheimer's disease is a disease is in a continuum, and a clinical spectrum is a continuum. It's a complex disease. There may be different diseases and different pathways for different patients, as far as how much neuroinflammation or vascular dysfunction or maybe comorbidities are affecting them, TDP-43, alpha-synuclein, etc. But one thing's really, I think all of us would agree, and the end goal isn't to give plaque-lowering mAbs. I think that the end goal is to respect people and their autonomy and empower them, because an accurate and compassionate and appropriate diagnosis that's delayed, I think, is care and justice and autonomy that's denied. So I think that's really important to be able to give that to people. There are, obviously we have first generation drugs. Right now we have, PET, molecular imaging and CSF. Ultimately, the blood biomarkers are coming, and I think they're all going to be first tier. This is something that we need to learn how to implement in clinical practice together. And so I'll stop there. And let's see, we're going to go through this and I think go through the questions.
We're going to get through what we can in the next about 10 minutes.
We have a hard stop in 12 minutes.
Yeah. So the next 10 minutes, I'll pick some of my favorites. And I think, I'll ask Henrik here, and I think you alluded to this, but what would you say is the biggest reason or obstacle why plasma biomarkers have not yet started to be used in the clinic, or not regularly?
It is starting to be used we have, for example, used neurofilament light in clinical practice for over 6 years in Sweden, in the Amsterdam lab. It's also been up and running, and in France. And the phospho-tau markers are just now starting to emerge in clinical laboratories. And those of you who work in the US and Canada, you have places to send blood to and get results back now. So, in Asia, there are also laboratories appearing now that can do this in clinical practice. The Alzheimer's Association QC program sends out more QC samples this year than ever before to laboratories that are doing this on a regular basis. And we learn a lot from this. But it's not easy to do the measurements, and it's hats off to some of these biotech companies implementing or developing the fully automated tests that can be run on the clinical chemistry workhorses. So I think now that we shouldn't overstate the hurdles. I think this is happening now, actually. But we still have to be careful and not overstate our ability to interpret the biomarkers. We should use them as indicators to risk profile our patients, but we should never make a diagnosis on the basis of a blood test.
Thank you, Henrik. And I think that's a really important point. The evaluation, the person-centered evaluation is really important. So as Henrik mentioned, whether it's the depression, whether it's a sleep apnea, whether they're drinking too much, it shouldn't be the case that someone shows up and they say, oh, well, your blood biomarker is negative. Great, you're done. Because, if they have symptoms, you have to figure out what's going on. And vice versa, you still have to figure out what's going on, and so the biomarkers have to be put in the context of an evaluation and integrated together.
And sometimes the tests will be wrong, and we know that from any aspect of medicine where you use blood tests, and so you will find macro troponins, for example, giving you falsely elevated levels. It's just try to keep your clinical hat on when looking at these results. That's and you can always overrule a biomarker result if it doesn't fit. And then you have these other modalities to continue to use if the patient needs further evaluation.
And I think that segues really well to this next question, and I'll direct it first to you. Given the advent of blood-based biomarkers, what role do you see for neuropsych testing?
They're completely independent, right? So one's telling you potential disease, my blood-based biomarker may be negative right now, but my CDR right now may be 0.5, right? So, and the other is really, in many ways, is a gold standard of looking at your cognitive functional profile. So they tell you something very, very different.
I also think it's very important to have both aspects, and that it doesn't have to be a neuropsychological test perhaps, but you still need to determine if the molecular change you have measured impairs brain network function. Because if it doesn't, then it's something else, and then, or you find you can find other explanations. It's very important to link the molecular change to some type of brain function test.
Yeah, I always find that more data is better too, to help you understand the diagnosis and options. So
And the neuropsych, the cognitive behavioral profile really also tells you about um, uh, how to manage that person and what plan you can individualize for their symptoms. If they're memory impaired, not to rely on their memory. If they're behavioral issues, to look at those things. So, um, symptom management is going to be also very important, guided by your clinical evaluation, including neuropsychological evaluation.
I think we might have time for maybe one or two more questions. So, back to you, Henrik. Do you think in the future NFL could work as a biomarker of vascular co-pathology in Alzheimer's disease?
It actually works relatively well in significant cerebrovascular disease as a general marker of neuroaxonal injury, and white matter tracts are rich in neurofilament light, but it's not specific. But if you have a patient with cognitive slowing, phospho-217 negativity, and NFL increased, and you don't think it's frontotemporal dementia, then it could well be that it sounds a little bit cerebrovascular then, small vessel disease. But it's not specific. And I also wanted to mention before we end that we also, of course, need to continue to work on blood biomarkers for TDP-43, alpha-synuclein, and actually cerebrovascular disease and neurovascular unit dysfunction.
Do you think that there is potentially a panel of biomarkers that would be maybe outperforming a single test approach in addressing these questions?
If you have a very clinical mindset and you see a neurology patient, you will, if you have a big practice, eventually see an early Creutzfeldt-Jakob disease, for example, or something else. So, and that is where brain-derived tau, phosphorylated tau, A-beta-42/40, NFL, a TDP-43 test, an alpha-synuclein test, all that would be so extremely handy. But we don't have the alpha-synuclein and TDP-43 test yet, but I'm sure some of you in the audience will figure it out. And other groups there are many people, there are so many people working on this. That makes me very hopeful that we will see that this is happening. There are extracellular vesicle data indicating that there might be something that you can measure in blood related to TDP-43 and alpha-synuclein, and I'm sure there will be breakthroughs here.
Thank you. Well, on that note, I mean, I'm very hopeful about the future. I think all of us are. It is the beginning with these treatments, and then I'm very excited about I can't say I have a favorite fluid, but I will say that this panel is very exciting because we need to get to this point of precision medicine where we can understand that patient. So the neuropsych maybe help us for understanding the cognitive deficits and strengths, but really understanding the comorbidities and maybe tracking over time. And watch for the online activity in the coming weeks. Please join us tomorrow where some of us will be there. Maybe we'll get a heckler in the audience, and we'll talk to you more about managing and practicing. Thank you so much for joining.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation of Continuing Education for Health Professionals. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/XSS860.